Thank you very much for joining us. We are coming to you from Marrakesh, Morocco, on the sidelines of the World Bank IMF meetings. We have some of the authors here with us in the room. We have about 30 people online. I think we're expecting around 100. We're here today to launch a special issue of BMJ Global Health focused on health taxes. We are very excited to be able to do this. There are already about 15 papers online and more coming in the coming days. This morning, we have a fantastic lineup for you. We are going to start with some reflection, some opening comments from the Alliance for Health Policy and Systems Research's Executive Director, Kumanen Rasanathan. We're going to then hear from some of our countries. So we're going to hear from our research team in Ethiopia and in Indonesia, in Ghana, and in Colombia. And then we're going to have some responses from our WHO colleague, Jeremiah Paul, JP, who leads the WHO unit on fiscal policies for health. So without further ado, I'd like to invite Kumanen to offer a few opening remarks. Kumanen, over to you, and we're looking forward to your thoughts.
So, Assalamu alaikum. Good morning, good afternoon, and good evening. And I mean, that greeting in Arabic, I think, is so prescient at the moment. And I just wanted to start by acknowledging there are tremendous challenges in the region. I'm aware, firstly, this meeting is happening in Marrakesh, which has recently, sadly, suffered a tremendous loss with the earthquake. Thousands of people have died and been injured. And really, it's testament to the resilience of people there that these meetings are still happening, that my colleagues are still able to be there. And so, but we're very conscious of that. And clearly, with events in Palestine and Israel and Afghanistan this week, thousands of people have died, different emergencies. It is a time when we really do hope for peace. With that though, I'm very delighted that this launch is happening today. There's an enormous amount of work from 14 country teams. I'm very much looking forward to hearing from colleagues from Ghana, Ethiopia, Indonesia, and Colombia. But to all of the 14 country teams, congratulations. It's a lot of work to get to this point, and to this for such an important topic about how can health taxes contribute to health and health equity, understand why we're not moving further forward. And congratulations to all of you. I think in the end, we expect to have 20 papers in the special issue of BMJ Global Health. And so thank you to Shea Abimbola, the editor, and the BMJ Global Health team. You're a tremendous partner, such an important voice now in global health. I know Shea was said to me that normally they don't want to have 20 papers in a special issue, but the papers were of such high quality that they allowed us this time. So we're very grateful for that. I'd also like to acknowledge the Government of Norway and NORAD, who have supported financially this work, and they're our great partners at the Alliance, and so we're very grateful to them. And then to our colleagues at WHO, not just JP, who's there, who really does know more about health taxes than probably anyone else on the planet, but also Tessa and the Health Governance and Financing team, Diarmid in the Climate Change Department. And we're also very grateful that our Director General, Dr. Tedros, has himself contributed a commentary for the special issue with the Right Honourable Helen Clark, and we're very excited about that. Finally, just to also thank our partners at the World Bank, UNDP, OECD, and Global Fund, who are members of the Interagency Working Group on Health Taxes. And then to Robert, to Kang Soo, and Adam, our team, who've really worked so hard to pull this together, to technically support the country teams and drive this forward. So a lot of people involved in this effort, and it's really great that we can have this event today to share experiences. And in the end, the papers are a means to an end for us at the Alliance. They're important milestones in themselves, but we really hope this knowledge can assist us to move more quickly in implementing health taxes. I think Most of the people in the room will know that since 2007, for all the evidence we have that health taxes as policy interventions work, the world's population covered by strong cigarette tax policies, for example, has only grown by 5%, let alone the other types of health taxes that we know can improve health and health equity. So we hope that these papers can really be an instrument that can help countries to move forward on overcoming the barriers to implementation of health taxes. We know that a lot of those barriers are political. Many of them relate to the commercial determinants of health, the lobbying efforts, often the misinformation as to why these health taxes shouldn't be implemented. Some of them relate to the infrastructure for implementing taxation, but that is improving in most of our countries. So what these papers have tried to do is to understand the ecosystem, the political economy, the context of countries, understand where they are with respect to taxation, understand where they are with respect to their public health strategies, and consider where have there been successes in the introduction of health taxes, what have driven those, but also understand what are the obstacles to improved implementation of health taxes. And so there are lessons in the first place for the countries involved, but there are also some lessons that can be generalized between countries. And so many of the synthesis papers attempt to identify those. And we hope that, as I said, this workshop, this launch, this supplement is just a sort of one milestone, but that all of you in the country teams will continue to use this knowledge to inform policymaking in your own countries, and that we as partners, whether it's the Alliance, WHO, the partners we work with, such as the World Bank and the OECD, can use this knowledge as we try to support countries to take forward implementation of health taxes. So we have many more countries using this instrument relate in a way that makes sense for their countries to address the commercial determinants of health, to reduce people's exposure to harmful substances, to realize the co-benefits that can be taken advantage of by the use of health taxes between health and other sectors. And so for us at the Alliance, and Robert has very much led this agenda on health taxes, this is just what we hope is the first part of our work. It's raised as many questions as it's provided answers. We've learned a lot by doing this with all of you, and we are committed to continuing our work on health taxes. As global partners, what can we do? We can support further research, of course, but even more importantly, we can support the brokering between research, evidence, and learning, and policy and implementation. For us at the Alliance, it's because we're hosted within WHO. It's our colleagues such as JP, such as Diarmid, such as Tessa, who lead the normative guidance to countries as they design their public health policies, which should include health taxes. It's partners such as the World Bank and the OECD who have much greater access to ministries of finance, where often the decisions for health taxes are made. And we really appreciate that we can work together. And as global partners, in fact, clearly we need to do better in supporting countries' efforts to implement to design and implement health taxes. Finally, just to say for us at the Alliance, moving forward in our strategy, in our draft strategy, we've identified 5 priorities, which I think all relate to our today's discussions, particularly 3 of them. Firstly is our work on universal health coverage and primary health care. And we know health taxes can be an important mechanism for revenue generation, but can also help be a fundamental public health policy to reduce harm. Secondly, around digital health, and maybe in digital health that can help us to better understand tracking and financing and what happens with the use of health taxes. Thirdly, non-communicable diseases. And here, work on health taxes is the cornerstone of the work we want to do on multi-sectoral instruments for primary prevention of non-communicable diseases. Fourthly, around climate, and we know that health taxes are an underused instrument for realizing co-benefits of the mitigation of climate change, with particular benefits for non-communicable diseases. And fifthly, around emergency response and preparedness. So I wish you all the best for your discussions today. Again, let's just see this as a start, and let's really judge ourselves by the extent to which this knowledge and learning actually moves the needle, actually leads to improved implementation of health taxes. So back to you, Robert, and very much looking forward to reading the papers in more detail. Some of them I've read, and hearing what our colleagues from countries have to say today. Thank you very much.
Thank you again coming in for those insights. We really appreciate your noting of the space for further progress on this important issue. We heard you that since 2007, the world has really only advanced about 5% on tobacco taxes, but we know that there's also more room to improve coverage rates around alcohol, around sugar-sweetened beverage, around other products, salt, sugar, fossil fuels, meat. There's a large, wide agenda here. And we're looking forward to learning today, hearing from some of our country colleagues, to hear about some of the stories from the countries, what's happening in the countries. And I'm delighted that we have time today to hear from colleagues in Ethiopia, in Ghana, in Indonesia, and in Colombia. And so without further ado, I'd like to invite Daniel Erku, who is a research fellow at the University of Gondar, up. Daniel, if you could come up to the podium and talk about the case study from Ethiopia. We're looking forward to your story.
Thank you. So I'll be talking about Ethiopia's experience in terms of passing the tobacco taxation back in 2020. So I think for the interest of time, I'm not going to be talking much about what health taxes are and their importance is. And I think we've got enough evidence that they work. They can decrease consumption. They can save lives. They can promote health equity, increase government revenue, and more. Maybe just I'll start by talking about the background, the tobacco legislation background in Ethiopia. So essentially, tobacco is owned by the government since 1948, with a suite of legislations up until 2016, when the National Tobacco Enterprise, which is the main tobacco producer and distributor in Ethiopia, has been part owned by the Japan Tobacco International. So that happened in 2016. So with that comes the big tobacco interference in the country. In 2014, Ethiopia ratified FCTC, but right after that, I think there hasn't been a lot of discussion around health taxes and tobacco control up until 2019, when the Ethiopian Parliament unanimously approved the EFDA bill, which is called the Ethiopian Food and Drug Administration Bill, which includes mandates on tobacco taxation, but also more generally on tobacco control and smoke-free legislations and things like that. So that was Africa's most strongest tobacco control legislation. So following that, the Ethiopian government also repealed the excise tax proclamation, which has been in effect for over 30 years. And what that means is now tobacco taxation has come into effect in line with the WHO recommendation. So even though these two important bills has been passed with a number of interest groups, stakeholders involved, we know very little about who is involved in the agenda setting and what are the power imbalances and different framings that are in play in shaping these policies. So my study aimed to shed light on that. So we did a stakeholder mapping and engagement to start with. We included as much stakeholders as possible except from tobacco industry, unfortunately, because we were not able to reach out to these people, even if we've tried. But we had a number of representations from the civil society organizations, from the government, from trade organizations, which indirectly represent the tobacco industry's interest. So we based our study on 3 data sources. The first is the policy and media document analysis. The second is secondary data from the parliamentary debate and public hearings. So what I can say about I think the first experience in terms of Ethiopian parliament having an open discussion and debate in the parliamentary history was the tobacco taxation bill. And it has attracted a number of media attentions and public submissions and witnesses as well. So we did analyze those videos and those public submissions, written submissions, and that was followed by key informant interviews and in-depth focus group discussions with different stakeholders. So our theoretical framework was based off of framing, or specifically issue framing, and even more specifically interactional issue framing. So I think it's very important that what kind of tactics and approaches are people using, or different stakeholders using to shape their policy, to shape their narrative. And one of these is essentially framing or issue framing, which is very critical for understanding decision problems. And research, especially in the social psychology research, suggests that these framings are usually underpinned by some sort of moral foundations. So stemming from individuals' moral foundations and values, they try to trigger emotional responses for policymakers and stakeholders. So we try to evaluate the framing moves adopted by policy actors and entrepreneurs. We try to analyze the underpinning moral foundations. We try to assess the impact of this framing context on shaping the final policy. So one main thing, I guess, is the window of opportunity in Ethiopian excise tax policy passage, which was that back in 2018, the new government was formed. On the background, there was a huge movement for domestic revenue mobilization. And one of the main source of that was excise taxation, not just on tobacco, but a number of products, including alcohol and sugary drinks. So that kind of opened the policy window for the EFDA, or the public health camp, to actually go into the debate and bring these things forward and finally into their passage. Expectedly, there were a number of common tactics employed by the tobacco industry, kind of creating a dystopian policy narrative and polarizing their framing by emphasizing, the unavoidable cost of such policies, from social justice point of view, from the economy point of view, and from even public health point of view. They question the credibility and sufficiency of the current evidence, and rather they based off of their own evidence, their own generated evidence, talking about illicit trade. Illicit trade is a big problem in Ethiopia. They mentioned about 44%. They raised concerns about the economic impact. They argued that the bill actually contradicted international tobacco control policies like FCTC. They actually specifically invoked the fact that the notion that this bill has been very strict, that people are becoming more Catholic than the Pope. That's quote unquote. Presented their own studies, like saying 44% of smoked cigarettes in Ethiopia are smuggled, which has some bearing for Ministry of Finance, which I'll talk about in a bit. Throughout these conversations, throughout these framings, they tried to invoke a number of moral values and foundations in their argumentation, one of which is liberty. So they portrayed smoking as a personal freedom and choice. And also they argued that the bill threatens civil rights and poses social injustice, talking about the government has nothing to do with dictating what people should say and should not say. So this framing hasn't really had a weight in terms of the parliamentary discussions in the final passage. And one of the reasons was a very concerted, a united front by the public health campaign, or public health group, which was led by the EFDA, the Ethiopian Federal Food and Drug Administration. And they employed a number of, I guess, very unique to Ethiopia kind of tactics. One of which I can think about is they engaged children in the parliamentary debates, have children in the parliament talking about their future and how the future is detrimental if smoking persists as well and addiction persists. They've also strategically employed or invited one of the previous director of the tobacco, the National Tobacco Enterprise, which is a big tobacco company in Ethiopia, who has been the director for about 17 years and smoked for 15 years. But I think he lost his son to cancer. And so this was, I think, near and dear to him. He founded Ethiopian Cancer Association, kind of a civil society organization, and he has been talking against tobacco. So his testimony was really moving for the parliamentarians. They also rejected the consumer choice argument and challenging the tobacco industry's moral stance, the foundational moral stance in the first place. They had influential rhetorical strategies, which led to some parliamentarians questioning, why are we talking about smoking in the first place? It was historical anomaly to have this product in the first place. So that was more of arguing about sensating strategy. It was generally kind of easy appeal to moral intuition to the parliamentarians, partly due to the cultural taboo surrounding smoking in Ethiopia in general. So there are a few controversies throughout the passage of this bill, one of which was the specific excise tax amount, which was 5 Ethiopian birr when it was proposed by modeling based off of World Bank work. But that was back in 2014. And in 2019, when the bill was proposed at the parliament, because of inflation and all that, it should have been increased to 8 Ethiopian birr. But the Minister of Finance rejected that claim and saying that any further addition on the excise tax would result in illicit trade. So easily falling for the tobacco tactics, the tobacco industry. So what WHO and other civil society organizations did was a concerted, a united front campaign and advocacy talking about this is a false claim. And they actually convened in Geneva. And finally, they were able to convince the Minister of Finance to take back on its argument, and then eventually it increased. They increased to 8 Ethiopian birr. The other issue was regarding earmarking, and due to the fact that it's very, very complex in terms of the policy and legislations to put an earmarking in Ethiopian financial or health finance system. The public health coalition kind of reframed the whole situation around earmarking to say that, okay, if you cannot put earmarking, let's just have an equitable distribution of these funds to make sure that some of the fund goes to public health priorities and curbing, smoking related diseases. So what are the takeaways, I think, from Ethiopia are, understanding and knowing when the window of opportunity, especially the political window of opportunity is open, is really critical. I think in Ethiopia, the public health campaign has been talking about excise tax from 2014 up to 2018, but hasn't been influential. But then in 2018, the government had this interest of domestic revenue generation, which then bears weight in terms of the arguments. The role of evidence, I think this is a presumption that the evidence should already be there. The modeling and the critical technical aspects should always be there, and any argument should be backed by that evidence. The other was a united front by the civil society organizations, which was so unique in Ethiopia in terms of being very organized, having everybody on board, having a bottom-up advocacy plan, a written, I think it was a 5-page advocacy plan they have written up and followed through for like 6-7 years. So a successful cultivation of an epistemic community and engagement with policy entrepreneurs is very critical. The other one is framing and argumentation. So trying to invoke some emotions into the parliament in a way that's positive for the passage of the bill. Those are, I think, critical takeaways from Ethiopia. But just one thing to mention before I finish is the tobacco interference is continuing to this day. Just a few months ago, the tobacco industry has signed a memorandum of understanding with the custom commission to prevent illicit trade. And I don't know how that happened, but the tobacco industry's challenge has been there, and we should be very cautious about that. Yep, that's from me. Thank you so much for listening.
Thank you very much for that case study from Ethiopia, Daniel. We're very interested to hear about that, and I'm sure many of the colleagues will look forward to reading your study, which I believe is already online, and we'll make sure to share the link in the chat. I'm delighted now to invite Dr. Arti Singh from Ghana to present. Arti, are you with us?
Yes, Robert. Yeah, I'm here.
All right, great. So Arti Singh is a senior lecturer at KNUST University in Ghana, and she's going to share her case study from Ghana. Arti, over to you.
Thank you, Robert. Thank you. Okay, thank you. So I present my findings from Ghana on taxing unhealthy commodities such as tobacco, alcohol, and sugary beverages in Ghana, and had a research team comprising of myself and some other colleagues from the UK and Ghana as well. So I would also not go into the details of health taxes and what they are and how effective they are. And but yes, I think the important thing is that we in Ghana have a big problem with non-communicable diseases, where NCDs comprise almost about 43% of Ghana's all-cause mortality. And just to give you a small recap of what Ghana is, a low and middle income country in West Africa with a population of about 30 million. And we have a big problem when it comes to tobacco and alcohol and sugary beverages consumption, because we don't really have a lot of data to support a lot of the findings that we have as compared to other countries in high income and other low and middle income countries. But with the introduction of the best buys in 2013, and one of them being excise taxes, we do have some work around tobacco taxes, but data around alcohol and SSBs are quite lacking. And yes, so the goals of my study actually was to really understand what the politics is around health taxes, what the opportunities and barriers are from key stakeholders, and also to examine what the public thinks about these existing taxes on these products, and whether we can think of probably improving these taxes to promote public health goals. And then the other objective that we had from our study was to examine the commercial sector views, so the industries, with the aim of understanding better their position and preferences when it comes to the key industries such as tobacco, alcohol, and SSBs. So how did we go about doing this? We had a review of the literature, the current literature, which involved looking through the scientific literature, evidences using scientific research, using media releases, policy documents, and some reports that are existing in the country and some sub-Saharan African regions as well. Then we also went ahead to do key informant interviews with 28 people that comprised of people from the government, media, civil society, NGOs, international organizations, and industries belonging mainly to alcohol and sugary drinks. And then we also did focus group discussions with groups of adolescents and adults. So 3 groups of adolescents and 2 groups of adults, males and females. And just quickly moving on to the findings, because I know we don't have much time. The main findings that emerged from our study was actually quite, we had both positive and negative findings. And some of the key findings really were that there's quite a number of supportive arguments when it comes to health taxes. Our policymakers were quite supportive, and they look at it from the point of revenue generation. Excuse me. And some of the barriers that came about was related to the fact that there's a lot of industry and political links. So we had observations where we identified that there was quite a lot of industry and political links when it comes to specifically the tobacco industry. And some of the stakeholders were also quite keen on the fact that they brought about these arguments about these taxes bringing about a political and economic loss to the country in the terms of course, the economic crisis that the country is currently facing. And then with the introduction of these new taxes, there were these arguments around the lack of accountability. So the stakeholders kept on mentioning the fact that we keep increasing these taxes, but there's little accountability and transparency when it comes to where these taxes and the money goes to. And then another observation was that there's a lot of unavailability of data and evidence when it comes to countries within the sub-Saharan African region. So like what we saw in Ethiopia as well. And then and the fact that we need more data and evidence from some of these countries in this region. And the impression about earmarking and whether we should use some of these to earmark for funds. Yes, there was quite a lot of support for earmarking these taxes. And it was more like geared towards the fact that there's a lot of attention already going into infectious disease. So like TB, malaria, and HIV are really taking in a lot of government funds. But NCD care is still lacking. And there was this argument that NCD care must be prioritized at the moment. And so earmarking these funds, some of these health taxes for NCD care it was quite a point that some of these stakeholders mentioned. But then there was also still arguments around the lack of accountability and how these would be spent as major challenges to earmarking these funds. And some of the recommendations that came about from our interviews with our stakeholders was that, of course, we need more data and evidence on health taxes in the country. And then we also need to reduce the industry and political connections that are quite pervasive, especially when it comes to tobacco and the government, tobacco industry and the government. And then also suggestions around reducing the advertisements of these harmful products. So particularly when it comes to sugary drinks, and reformulating some of these sugary beverages was some of the recommendations. And of course, thinking about some different ways of marketing strategies. Our industry, I think, really resonates well with what we saw in Ethiopia from Daniel's finding, where the industry keeps talking about the illicit market and increasing smuggling when it comes to increasing taxes on some of these products. But we've all seen that there's not much link when it comes to illicit trade and increasing taxes, because we have seen much lower illicit trade in countries which have actually very high taxes as well. So there's really not much evidence to support that. But the industry keeps using that fact. And they were not also in favor of anything like earmarking these taxes on the same grounds that there's little accountability and transparency when it comes to introducing these taxes and how the government uses these funds. Talking to the public, so the groups of our adults and adolescents had similar views in terms of supporting health taxes, both for health gains, so the goals in terms of public health goals, and of course, increasing revenues when it comes for public spending. And then they also mentioned that it contributes to a positive societal change. But there were concerns related to the same points that the stakeholders mentioned, where there's little transparency, and we don't know whether these are effective when it comes to people who are addicted. And it might have some negative effects on people who work in these industries, so like job losses and economic losses for some groups of people. And then they also had recommendations around a lot of the need for advocacy and education on these products, and introducing new ways of marketing these products and looking for healthier alternatives for some of these products, especially sugary drinks. But there was a lot of support when it comes to taxing sugary drinks and alcohol as compared to tobacco. So in terms of my takeaways from some of the findings that we had, I think the main, some of the key points that really arise is that we need to address the issues around industry interference and influence and government links. So industry political links is something that we need to really look out when it comes to some of these countries within the region. And the importance of increasing public and political awareness on some of these topics, such as health taxes and the related public health impacts and goals. And then we also need to think about addressing some of these novel products that are actually emerging. So electronic cigarettes, which are also new product that is coming into some of these low and middle income countries where we don't really have clear laws and regulations around these new products. And then, of course, like I mentioned, capacity building and awareness of stakeholders in taxation and health impact related to these taxes is something that we need to think about. And of course, future studies as an important research goal at the end of the day when it comes to health taxes and public health goals. But just on a lighter note and maybe a positive note, that as we were continuing this study and getting to the end of our data collection, Ghana introduced excise taxes, which was an amended excise taxes on some of these products. And we increased the taxes on tobacco, alcohol, and introduced new taxes for sugary beverages just at the time that we were trying to conclude our study findings. So I think this brings me to the end of my presentation, and thank you for the audience.
Excellent. Thank you very much, Arti, for those insights. We were very glad to hear about your work in Ghana. Very glad also to hear about the introduction of new taxes there, and we will watch that closely. At this point, I'm happy now to invite Dr. Abdullah Ahsan, professor from University of Indonesia, to now share his case study on Indonesia.
Okay, good morning. I'm Abdullah Ahsan from the University of Indonesia. This is with my team and also from the Demographic Institute, Faculty of Economic and Business, University of Indonesia. We have a review, or our paper is about health tax in Indonesia, review of policy debates on the tobacco, alcohol beverage, and sugar sweetened beverage tax in Indonesia. And as you know, for the background, Indonesia, in terms of these three products, tobacco, SSP tax, and alcohol. For the tobacco, we have not ratified the Framework Convention on Tobacco Control. Our smoking prevalence is very high, especially for the male adult. For alcohol, because we are a Muslim country, consumption of alcohol is very low. For the SSP tax, sugar sweetened beverage is very popular currently, and they are increasing very high in the last 10 years. So the WHO best buy in controlling NCD and the risk factor is to impose a health tax. The imposing health tax will increase the price and reduce affordability of harmful commodities and create additional government revenue. And this additional revenue could be allocated to finance the public health sector, the universal health coverage. Yeah? And Indonesia currently has the least number of excise goods. We only have 3 commodities currently being excised: tobacco product, ethyl alcohol, and beverage containing ethyl alcohol. And the government currently is considering the sugar sweetened beverage and plastic tax for the excise tax. And the regulatory framework in Indonesia is highly rigid, which combined with the lack of technical guideline, result in disagreement and conflicting interests. The media framing built the narrative on public policy debates, and ignoring the media effect could undermine the policy agenda setting. The objective of the study is to review and analyze the main arguments on health tax in Indonesia national media. It is an exploratory and qualitative approach to generate government, politician, industry, and public health public perspective. The media analysis is the collection method. Yeah, the data collection method is using the media analysis, and the scope of this paper is about 3 commodities: tobacco product, alcoholic beverage, and SSP tax. So we analyzed the news article from the open source intelligence database. We conducted from 4 July 2022 until 7 July 2022 using relevant term or query and only in Indonesian language, and we use the NVivo version 12. So this is the chart of the news that we analyzed. So we have 11,000 something news article from the OSIN database, and we selected 9,900. And for the detail, you can read the paper. Yeah. And as the result, the health tax policy dynamic in Indonesia during the election years, the health tax policy primarily on tobacco tax were modified. In the 2019 election, the health tax policy have been changing considerably, particularly pre-election years. First, there was no increase in tobacco tax tariff in 2018. Second, a cigarette tax was implemented for the first time, but delayed 4 months due to the relaxed regulation. Thirdly, alcoholic beverage tax tariff was increased for the first time since 2013. Finally, the 2019 proposal for SSB tax was not discussed further until 2021. And currently, for the current situation, the SSB tax has been delayed 3 years, and the government still planning to implement the SSB tax in 2024. And we identified 25 actors whose statement are most frequently cited by the media from January 2018 to July 2022. 5 key actors, 3 from the MOF official and 2 from the NGO, overlap for different commodities. And the minister, the SMI, the minister was featured as the top of the 10 most cited actors in all commodities. However, she was not the main figure in the news on alcoholic beverage. The industry-related statement on tobacco tax were more prominent among the MOF official. For the SSB tax, the MOF official statement had more public health term in the SSB tax context. MOF official featured across all commodities, indicating policies are moving in the intended direction, with MOF as the main actors in health tax implementation. So this is the conclusion that open competition, multi-party system in Indonesia create demand and supply for political support from the industry. So it creates political entrepreneurs. They do the rent seeking and rent extraction to gain campaign sponsorship from the industry. So we consider the election as a window of disaster for the public health, because the politician want to collect the support from the industry, and it is not bad. It is bad for the public health. And also, complex policy process in tobacco control is tightly related to the sizable market share. Tobacco industry is a big business in Indonesia. The richest person in Indonesia is tobacco industry owner. Yeah. So rigidly divided authority we have in Indonesia. We have the term is sectoral ego, that each ministry has their own objective and they are fighting each other. So, and then the structure of the government created or resulted in the string of power of allies of MOH. So MOH's role is very limited and insufficient media coverage from MOH tax on health tax. MOH focuses more on the non-fiscal measure of NCD control. The discussion have 3 main challenges for health tax policy from the media debate. First is there is a policy contestation. The second is the election. And the third is the lack of public health supporters, particularly from the MOH exposure in the media. So this is from the Indonesian cases. Thank you for your attention. You can find the detail of this paper in the Global Health special issue. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Excellent. Thank you very much, Abdullah, for that story from Indonesia. Very interesting to hear and learn about the experience there. Of course, your paper is also online, and so we invite participants to find that and read more there. And of course, they can contact you if they have any questions. At this point, I'd like to invite Blanca up to present from Colombia. Blanca is the research director at the Fundación ANAS, and she is just getting her study started in Colombia. So we thought we wanted to invite her to tell and share with us her plans for her study going forward. Blanca, we're looking forward to hearing more about Colombia.
Well, I hope we can share the slides later, but thank you, Robert. I am speaking on behalf of my team in Colombia and also Luz Miriam Reinales Shigematsu from the National Institute of Health in Mexico. Norma Maldonado, Ginette Araujo, Diego Garcia, and Alejandro Marin are also part of the team in Colombia. So thank you again, not only for the opportunity to speak today in this event that is a closing moment for many of you, but a starting point for us, for the rest of the group. Okay. I think in the case of Colombia, we have a lot to bring to the game in terms of providing the opportunity to reflect upon what I call a natural experiment, because Colombia is facing today 3 different circumstances regarding tobacco, SSBs, and alcohol. In tobacco, we have a first win after many, many years of stalling and having one of the cheapest cigarettes in the region. We tripled the tax in 2016, and we started to observe the benefits that were expected. Big drops in consumption, a contribution to the 1 million fewer smokers in the decade, largely comes from this tax increase in the country, which is, by Colombian standards, a big win. We have about 4.5 million smokers, so having a drop of 1 million is a significant win. We still have a long way to go in terms of tobacco taxation, of course, because we are still in the top 5 cheapest cigarettes in the region, despite this encouraging advance. So that's the story in tobacco. First win, but still long way to go. On SSBs, last year, the government started an initiative that was approved by Congress that created, for the first time, a selective tax on SSBs and other and ultra-processed food, certain groups of ultra-processed food. So what we have there is a situation of certainly an advance with the new tax, but a lot of uncertainty. There are uncertainties about the results in terms of if the design was effective enough to reach the health goals that we want, if it's creating unnecessary distortions in the consumer decisions. We need to monitor these results. And based on those monitoring results, we need to review this tax design probably. And obviously we need to protect the tax from industry tactics. Over this past year, we have faced 3 different lawsuits challenging in the courts the tax, and we are awaiting the Constitutional Court ruling to define if this tax is going to survive or not. We hope that this is the case. But again, this is a situation of advances and uncertainties. And third, there's alcohol that I call the no man's land. This is the forgotten commodity. And it is the most consumed psychoactive substance in Colombia. Huge connections with violence, which is a very heavy topic in terms of the policy agenda. And of course, in terms of health burden. We still have to improve the design. We have a very poor design of the tax. There's a preferential treatment on beer. And in our opinion, that would be the main goal, to improve the design and to reduce the distortions across products. There's also an exclusion of low alcohol content of any tax. They are not subject to any tax. So lots of challenges there in alcohol, because we still are at the, I would say, at the starting point there in terms of the creation of the evidence, discussion of the design, and lots of challenges in terms of implementation as well. So why is ANASH participating in this initiative? And we are really, really thankful for the opportunity. Basically, we see very clear that this provides a lot of input that is clearly needed for countries like ours. It's an opportunity to generate knowledge. It's an opportunity to build national capacity in our country, to continue the work of researchers in my country. And it's also an opportunity to compare results with using common frameworks with other countries, which is much needed. And hopefully that will bring light to future research and more impactful research. And what we plan to accomplish with these inputs is to improve our ability to map stakeholders, to understand their attitudes, to gain an understanding also of the power relations and the incentives behind their behaviors, so we can be ahead of the game. We can predict better, and we can be better prepared in terms of advocacy. And also, obviously, understanding the barriers, both for effective tax design and for implementation. Among the topics that we want to explore, and I won't get into much detail here, are obviously, and this has been mentioned this morning, the commercial determinants strategies in our country. How do they use information and disinformation? How do they build constituency and alliances? How do they use financial incentives and other incentives? How do they use legal actions against taxation? Understanding the narratives of the policymakers is also an important part, and many of my colleagues have shared some insights from their own countries, and we hope to bring the Colombian evidence to the discussion. And also, very importantly, the institutional conditions, understanding the civil society role, the role of the media, the transparency and requisite for effective participation in policy making of the legitimate actors. And these nuances of the power tensions between government sectors and different levels of the government, national, subnational, and across branches of power, Congress, executive, and legislative. So this is what we hope to explore in our case study. Finally, some expectations that I hope that my colleagues from the second cohort share, and that come from, attempting to summarize some of the conversations that we have had over this week. First, I think it's very important that we have the opportunity to build an active community of practice. So I think the Alliance is bringing this to the table. A community of practice around health taxes, understanding health taxes as a broad field, not just in a compartmentalized way, individual products. I think this creates a potential to increase dialogue across disciplines and a more cohesive approach, not only in terms of research, but also in terms of policy practice, of what the concept of health taxes means and how it's important to be considered a distinctive policy tool. And I have already mentioned, but I will mention it again because I think it should become an obsession for us, is analyzing commercial determinants of health and their role in the political economy, to understand why health taxes, and this is what we repeat over and over again in every meeting when we talk about non-communicable diseases prevention, the most cost-effective policy tool and the least implemented. So understanding the political economy is a key part of that. And hopefully this will not only help us understand the individual conditions of each one of our countries, but also bring up common lessons that could truly help us scale up the experiences of successful experiences of health taxes. And finally, we hope that this steps up the implementation research because implementation is the name of the game here. So thank you. And we hope to be up to these expectations.
Excellent. Thank you very much, Blanca. The most effective policy tool to save lives, to raise revenues, and the least implemented. Thank you. I think that was a great presentation, a great way to end the perspective that we're hearing from the countries. We're of course all very excited to see what you do in Colombia, but also across our other countries in India, in Uganda, in Zambia, in, well, so I want to make sure I'm not forgetting any of the countries, Mongolia, of course. We have in Nigeria teams moving forward. So we're very much looking forward. We are in the process here of building a community of practice, as you say, and we're hoping that we can indeed have a more cohesive, coherent, adaptive response to support countries in moving forward on health taxes. So at this point, I'm excited to invite Jeremiah Paul, JP. He is, as we've heard before, WHO's unit head for the unit looking at fiscal policies for health. JP, you not only lead that, but as I think Kumran said, are probably the one person in the world that knows the most about health taxes. You have great experience in the Philippines. You have in-depth knowledge of this issue. What we're keen to hear from you, JP, is your reflections, your responses. What do you think about these case studies? You've been, of course, with us here over the last few days. We're keen to hear your thoughts and how this sort of work can be useful to advancing health taxes. So JP, if we could invite you up, we'll look forward to your thoughts.
Yeah, thank you very much, Robert, for your kind words. First of all, I'd like to start off with what Robert was saying, that health taxes are the most effective yet the least implemented health intervention to reduce and prevent non-communicable diseases. And I also like to congratulate the researchers and the Alliance for doing this work. This is really timely because going back to that fact that these are really very effective. They've been identified as cost-effective instruments to prevent NCDs, but they're really not implemented. So one is that, first is that the role of evidence. No? I mean, we have a lot of evidence that this works, whether you're talking about tobacco, alcohol, or SSBs. Increasing taxes that lead to an increase in price really has a lot of evidence that they reduce consumption. However, even though if they're very effective, you can expect a lot of opposition. The researchers mentioned in Ethiopia, for example, illicit trade, the same thing with Ghana. In fact, expecting opposition from powerful industry interests and vested interests is a given. My team has worked all over the world, and we see this. In fact, in the tobacco tax manual, we have an acronym. We call it the scare tactics, or similar adaptation for SSBs and alcohol. As is really, if increase smuggling, and if you increase tobacco taxes, for example, you increase smuggling and illicit trade. Or in the case of SSBs, they can sow doubt on the evidence. So C essentially stands for court and legal challenges. We found the example of Colombia that there were court challenges on their attempts to raise health taxes. A, you hear this also very often. It's raising taxes. Health taxes are anti-poor, so you should not do them. Or if you raise taxes, instead of revenues going up, revenues will go down. The other one is the negative employment income, or E, the employment income. So wherever you go, there will always be opposition. Expect opposition, that's a given. So how do you counter that? You counter that by building evidence. There's a lot of evidence already, but as what was pointed out, there may be a need for country-specific evidence. At least for low and middle-income countries, that is also increasing. But clearly, when you're going to counter strong opposition, you need to gather a coalition of reformers. Whether these reformers come from government, inside government, whether they come from academia, whether they come from civil society. That's the only way you could probably counteract the strong opposition from this vested interest. Which leads me to another point, which was also raised in the case of the Ethiopia paper and even in the Ghana paper on the importance of framing. Framing the issue, whether as a universal health coverage issue or as an NCD prevention issue. Because if you look at it, health taxes is a means to an end. It's not an end by itself. And it is what our goal is really to prevent non-communicable diseases. And in the context of tight fiscal deficits, which many countries are facing post-COVID, where there is also pressure to protect health and social budgets. I think one of the most effective avenues is really to prevent these diseases from developing further. It's much cheaper to prevent diabetes rather than to treat it using dialysis, for example. So it's really important then that we need to have this coalition of reform backed by evidence. So there were also a number of issues that were highlighted. One was on the issue of earmarking. What's the position of WHO in an earmarking? Earmarking is a secondary issue from raising taxes. Again, raising taxes is important because they raise prices and they reduce consumption. Taxes by itself do not affect consumption. It's through their impact in price, because sometimes the industry can absorb the price increase even if there's a tax increase. If there's no price increase, then there's no consumption impact. So the issue of earmarking comes to the fore if, from a political standpoint, there would be more political support for raising health taxes. In fact, a survey done globally showed that there's a lot of public support for raising health taxes, especially if the public can see where this revenues will be channeled, whether it's going to be increased health expenditures, increased social expenditures. So if industry wants us to believe that there's no public support for raising health taxes, the evidence shows otherwise. In most countries, there's public support. And one way to do that is really through earmarking. I mean, earmarking in the soft sense, because many ministries of finance around the world are against earmarking per se. But if you have soft earmarking, in other words, the revenues goes to a common fund, and from there it's distributed through the budget. The other thing is capacity building. We're in WHO, we do capacity building for government officials, finance and health, also for parliamentarians. So, because we need to engage people from all sorts, whether from civil society, from academia, whether the parliamentarians or the government officials themselves. So we are working closely, WHO works closely with the interagency working group on health taxes, of which the Alliance is a member. So I'd like to thank really the Alliance for opening up this research on the political economy of health taxes, because from a technical standpoint, doing the design, the revenue simulation of health taxes is quite straightforward. However, if you're talking about having it passed and implemented well, that requires a lot of political will and a lot of political savvy. Because as I've said, when you want to raise health taxes, you can expect a lot of opposition from powerful industry and vested interest. That's why knowing what buttons to push, how do you strategize, what are the key factors to determine what is the appropriate framing, is really a good subject for research. And it requires a multi-sectoral approach, an interdisciplinary approach. Thank you very much.
It's okay. Okay, excellent. Thank you very much, JP, for sharing those insights. We, of course, have benefited from that over the last few days here. But I think you've reminded us about the scare tactics, SCARE, that industry uses. Of course, we know this and understand this increasingly under the increased work on the commercial determinants of health, and understanding, I think, the opposition to health taxes in the framework of commercial determinants is, of course, useful. We also need to understand which evidence works where, when, why. And we know that the same evidence doesn't always work in the same place or in a different place. So we need to be able to be responsive. We also know, and it's related to which evidence works where, when, that how we frame the issue is really important. And I think, as you noted from the case studies in Ghana and in Ethiopia, understanding how and why, where we frame the issue of health taxes matters. It affects, it influences, it shapes implementation. And that's why we're very happy to bring together these researchers with policymakers to help understand this, to help illuminate this, to build a community, to try to shape social movements, to try to connect and advance on health taxes. And you know, as I think we've discussed over the last few days, we're really hoping to be in a place where we can be setting the agenda, where we can be not only anticipating what the industry is doing, but actually being in a position where we are forcing the industry to anticipate what we're doing and responding to what we're doing. We are in a place where we can be setting the agenda on health taxes, because we know that they save lives, because we know that they raise revenues. We know that if they're well designed, they can also be tools to improve equity and other government or social objectives. So Thank you again, JP. Really, really useful to have your insights, your advice and guidance partnership throughout this program. Colleagues, we're a few minutes over. Please accept our apologies to those of you online and those in the room for being a bit behind schedule. But we're very grateful for the opportunity to have this conversation, to have this discussion. And thank you for bearing with us with some of the technical difficulties. At this point, we're about to conclude, but I again just want to say a big thank you for the technical support here in the room. A big thank you to all of the research teams. Congratulations. You can find the papers online, and as we heard at the beginning, there's a few more papers that are coming in line in the next few days, so please stay tuned for those. And we look forward to staying in touch. Thank you very much. All the best.